The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. My name is Juliana, and on behalf of ISQua, I would like to welcome you all to today's webinar, Medication Safety and the Introduction and Evaluation of Intervention with Professor Bryony Dean Franklin. We are extremely honored to have Bryony Dean Franklin with us today, who currently is Director of the Center for Medication Safety and Service Quality, a joint research unit between UCL School of Pharmacy and Imperial College Healthcare NHS Trust in London. And I would like to say a few words about Bryony by way of introduction. Professor Bryony Dean Franklin is a clinical pharmacist by background and currently also chairs the Center for Patient Safety at Imperial College. She has been involved with medication error research for 20 years and has published extensively on methods for studying errors and the frequency and causes for prescribing, dispensing, and medication administration errors. Most recently, she has become involved with the evaluation of various interventions and technologies designed to reduce the errors. Just to remind you that Bryony's presentation will last approximately 45 minutes, and we will leave 10-15 minutes at the end for any questions that you may have. I'll pass the control over to Bryony now. Over to you, Bryony, now.
Hi, good morning. Well, I don't know if it's morning or lunchtime or afternoon to you, but a good day to you from West London. I hope everybody can hear me okay. I'm just going to put my slideshow on, and I hope that everyone can now see my slides and hear me.
We can see, and that's perfectly.
Fantastic, thank you. So as I say, welcome from West London. It's sunny here in my house and I'm looking out in my garden at the spring, so that gives you a bit of context about where I am at the moment. So we're going to be talking about medication safety and interventions surrounding medication safety. I'm going to have a little bit of a hospital slant to this presentation because we can only fit in so much within a 40-45 minute presentation, but I'll also be touching on some examples from community and primary care as well. So just by way of a bit of context and background, for some reason my slide advance doesn't seem to work. Okay, brilliant. So medication, as you may know, is the most common healthcare intervention used today. I think it's fair to say that nearly every patient admitted to hospital will be prescribed medication. And within community care, certainly in the UK, we know that about 2/3 of all patients who are registered with a general practitioner in primary care will receive at least one prescription in any given year. So this is a very common intervention. But while it is common, and in some ways we think of medication as being a relatively straightforward intervention, we also know that things do go wrong. We know from international systematic reviews that prescribing errors occur in around 7% of all inpatient medication orders. We know that administration errors occur in around 8% of all doses given in the hospital setting, and that excludes wrong time errors. If we included wrong time errors, then that number would be far greater. The number is also much higher if we look at intravenous medication, which typically has a much higher error rate. In terms of the impact on patients, we also know that around just less than 4% of all unplanned hospital admissions are due to preventable adverse drug events. And these are all international data. Most countries have country-specific data available as well. And we also know that around 1 to 2% of all patients admitted to hospital are harmed as a result of medication errors. So huge numbers, partly because medication is so commonly used and partly because it's not as straightforward as you might otherwise think to get things right. We also know that patients are becoming increasingly aware of the risks. This is a newspaper headline from one of the big, fairly well-respected daily newspapers in the UK a year or two back, and reports on some work we did on medication errors made by general practitioners in primary care. We looked at prescribing and monitoring errors made by GPs, and it created, a huge amount of interest within the media, resulting in headlines such as this one, which is perhaps a little sensationalist, but certainly indicates the degree of interest amongst the public and amongst journalists about the issues. So what are we going to do about this? Well, I think a common response within the healthcare setting is, let's go and do an audit. I just love this little character when I found him on the internet, but I think it really sums up what is often a common response within healthcare about, let's go and do an audit. We'll audit all the things. But obviously doing an audit is only going to tell us a very small part of the picture, and in terms of leading to demonstrable change, it's probably not where we want to be going. So what will we do about it? Well, what I want to highlight in this presentation is what some of the key issues are in developing, evaluating, and also publishing and sharing on the interventions that we do to enhance medication safety in clinical practice. I'm just trying to get rid of a notice that keeps flashing up on my screen. Hopefully that's done it. So that's what we'll be covering over the next half an hour, 40 minutes or so. So let's start with thinking about developing interventions. The first thing to think about is what the problems are, whether this be locally or nationally. I've put here a few points to perhaps start debate in this area. I think a key thing is not to assume that the problems and therefore the right solutions are the same in your setting as they might be elsewhere. Some of the problems and issues will be the same and some will be different, and it's often important to find out what those are. It sounds kind of obvious, but it's surprising, certainly within medication safety, that I think there's often an assumption that everybody does things the same way as you do. But what we know is that there's very wide variation between settings, between countries, and even between and within different settings and countries. And I've put a few examples here on the slides. So if we think about specifically medication, is prescribing paper-based? Is it electronic? Do hospitals routinely provide discharge medication? Do they not provide discharge medication and patients go and get medication in the community after they've been discharged? Do hospitals use CPOE? Is there transcribing of prescriptions from paper to an electronic system? Is everything paper-based, as it is in most UK hospitals? And what about supplies of medicines? Are they original packs? Is it unit dose? Is it some hybrid system? How is medication prepared? In some settings and countries, nurses prepare medicine immediately before it's due for each patient. In others, it's all prepared in advance for the 24 hours ahead, perhaps on the night shift, and all got ready for the patients that just needs to be given out to the patients in the actual day. And what I tend to find is that I think we all assume that everybody does it the same way as we do. So I know the pharmacists, particularly the more junior pharmacists and doctors that I work with, are absolutely amazed to find that other countries of the world don't use a drug chart, or that they don't use discharge prescriptions, for example. And as I say, we also know that there's wide variation even within the same countries and settings. I've put two references here on the slide for recent studies that we've published based on some national surveys of inpatient medication systems and electronic prescribing systems in English NHS hospitals, showing that even within one national health system in one relatively small country of the world, England, we've actually got enormous variation in practices. So being aware of some of these issues is often important, and it's also important when interpreting the literature. So if we read about an intervention that's dramatically reduced medication errors in another country, or even in another hospital in our own country or in another primary care area, it's important to think about what their baseline system was before they introduced the intervention. If their baseline system is very different to our system, then we can't necessarily assume that we will achieve the same benefits from their intervention. So something quite important about understanding the context, the problems, and whether or not they might be generalizable to your context locally. So what other ways can we use to find out what our problems are and therefore what suitable interventions might be? I've put a few examples here of some of the various methods that could be used. They're just some of many. But just to take some of these, so many organisations now have incident reporting systems, which are obviously important and really useful in highlighting some of the things that take place. There's an obvious caveat with incident reports that there's enormous underreporting of errors. The literature would suggest that only about 1 in 100 and probably something more like 1 in 1,000, sorry, 1 in 100 prescribing errors and something more like 1 in 1,000 medication administration errors actually get reported on a hospital incident report system. Data for the community setting is probably even more dramatic. Certainly in the UK there's very low levels of incident reporting in the primary care setting. So given these levels of underreporting, we can only use incident reports as examples of the kinds of things that go wrong. What we can't do is make quantitative conclusions about which incidents are most likely, which are most common, whether reporting rates are going up or down. Really they're just examples of what people have happened to report, because to report something you need to know that something has gone wrong, which you don't always until afterwards, and then somebody needs to know how to report it, be motivated to report it, have the time to report it, to not feel there's any barriers to reporting such as fear of retribution, and so on. So as a result, there's really enormous magnitudes of underreporting. Other methods that can be used are talking to staff. I've put here focus groups, but this could also be much less formal things, interviews, suggestions boxes about the kinds of problems that people face in their everyday practice. Now obviously these only tell us what people perceive to be the problems, but often staff on the ground have a pretty good understanding of the sorts of things that can go wrong, and used well this can be a really helpful way of finding out what some of the issues are. I have also, having been slightly saying audits aren't necessarily always the answer, I've obviously included audits in here because auditing some key outcome measures such as missed doses, pharmacist interventions, prescribing errors, completeness of prescriptions, whether patients have all the information that they need when they're discharged from hospital, whatever it might be, can also be really useful in highlighting where there might be systems failures and problems that could be addressed. By formal studies, I mean perhaps using more research-based methods such as observation of medicine administration or observation of dispensing, or a case note review looking at prescribing, looking at evidence of adverse drug events, or matching up documentation after patients have been discharged to identify medication reconciliation problems. There's a whole range of other methods that can be used that are perhaps more time consuming but give you much more in-depth information into both what the problems are but also what some of the reasons for those problems might be. So that's just to illustrate a few of the possible approaches that can be taken. Other important things to think about when developing interventions are who are the stakeholders. If we think about the hospital setting, for example, when people are considering introducing some change, if we're talking about medication, it's often very easy to think about the key people, the doctor and the pharmacist and the nurse. But there's often many more key stakeholders too that have to be considered. When we've spoken to hospitals who've introduced hospital electronic prescribing systems, for example, there's often a tendency for this to be very much led by doctors and pharmacists, and the nurse often gets forgotten, even though nurses will often be one of the biggest users of a hospital electronic medication system. But even if we remember the nurse, what about the dietitian who will have to prescribe dietary supplements and nutrition or specialist feeds for the patients? And what about the patient's health? How do we take that into account? So really important to think about all of the issues that might affect the whole range of stakeholders in the system. As well as thinking about the stakeholders, we also need to think about what the barriers, what the facilitators, what the challenges might be of implementing our change. And each of these stakeholder groups will be aware of different barriers and also have different things that will facilitate making some change or introducing some interventions. I've mentioned briefly plan, do, study, act cycles here, which I'll also come back to a little bit later as what can often be a practical way of starting to develop iteratively an intervention that's then introduced and developed iteratively in the process. I'd now like to consider some things relating to the evaluation of interventions. We've got the how many type questions, which are relate to our quantitative methods, and we've got our why and how questions, which are usually best answered using qualitative methods.
Bryony,
Quantitative.
Bryony, sorry to interrupt you. It seems that we have lost you for the last minute or so.
Okay.
So if you can just go from the start of this types of question slide again, because we couldn't hear you at all.
Okay, no problem. So if I go back from here, I hope that will then cover the bits that we missed.
Exactly.
Perfect. I don't know why that happened. So just to go back then to evaluating interventions and what the research questions might be. So I guess all of us working within healthcare and in healthcare quality improvement, the main question we perhaps want to answer is how do we increase patient safety, or specifically for medication, how do we increase medication safety? And we can then break that down into a number of component research questions, such as what are the problems, how often do they occur, why do they occur, what might the solutions be, and then coming on to questions such as what does work, what works best, and if we start thinking about the economics of different possible solutions, which are the most cost effective. We note that these first four questions relate to developing interventions, and the last three questions relate to evaluating interventions. So these questions really fall into two main types. We've got the how many type questions, and we've got the why and how type questions. How many type questions are best answered using quantitative methods, and these will include things like audits, surveys, observations, counting things in case note reviews, looking at clinical outcomes, and in some ways the kinds of methods that most healthcare professionals are most familiar with. Qualitative methods are better for answering questions such as why and how, and these will include observations, interviews, focus groups, and also some other methods such as a more in-depth document analysis where you're looking at qualitative type questions rather than counting things. And often we need to use both of these kinds of questions in terms of evaluating interventions. Just to highlight some of the key characteristics of quantitative versus qualitative methods. I don't propose to go through this in detail, but just to highlight that the quantitative methods are focusing on measuring and counting things, and would often then use methods such as statistical analysis, comparing groups, hypothesis testing. Whereas our qualitative methods are much more geared towards exploring reasons behind things, perhaps generating our hypotheses, and we're certainly not using anything to do with numbers within those. So I now want to spend the next few slides considering some important issues in using quantitative methods for the evaluation of interventions around medication safety. So some important issues to be aware of when using quantitative methods, and these apply in any sector of research really, not just medication safety. Will be things such as define what you're counting. It sounds really obvious, but it's surprising how often this isn't clearly done. Quantitative methods involve counting something. We have to know exactly what we're counting in order to be able to count it in a way that's clear, systematic, in a way to ensure that different people will be counting the same things and that we're comparing like with like. As well as defining what we're actually counting, we also need to define our denominator if we have one. So are we talking about some kind of adverse event per patient day, per drug administered? And we need to clearly specify what we mean by drug administered or patient day or patient or whatever that might be. We also need to think about the choice of data collection method, and I'll come on to this in a few slides' time, and its validity and reliability. We need to think about sampling strategies, and we need to think about study designs. Now many of these are common to all kinds of quantitative health services research, so the ones that I'm going to specifically pick out to focus on here are ones that I think have got particular issues for medication safety research. So the issue of definitions, both of what we're counting, the numerator and the denominator, the data collection method, and a few thoughts about study design. So first of all then, definitions. We know from the literature that there's really wide variation in published error rates. I've just put a few examples here on the slide. So if we look at published rates of prescribing errors in the hospital setting in England, a whole range of relatively rigorous studies have been conducted, and error rates range from 1 to 15% of inpatient medication orders written. Well, why that variation? Is it that some hospitals are much safer than others? Well, actually, no. I think it's mainly that researchers have used different definitions for what they count as a prescribing error. Similarly, internationally, another example, if we look at the published dispensing error rates in community pharmacies, I've seen studies which vary from 0.04% of dispensed items to 24% of dispensed items. Again, is this telling us something about relative safety of different community pharmacies? I suspect not. And again, if you look closely at these studies, this variation is at least largely down to variations in the definition of what's being included as a dispensing error. Now, obviously, there might also be other underlying reasons for the difference, but it's actually very hard to pick that out when you've got such enormous variations in the definition that's been used as a dispensing error. So let's see if we can illustrate the problem of definitions. This is all about what it is and isn't an error. So if we imagine a continuum stretching from one extreme to another, at one end of this continuum, one end of the extreme, we've got perfection. So this is a little halo. It's supposed to represent a perfect prescription or a perfectly dispensed prescription or a perfectly administered dose. So the drug is right, the patient is right, the dose is correct, everything is appropriate for the patient's clinical condition, it's been perfectly documented and written down, absolutely everything is just spot on. Even
Once again, we have lost the audio connection at the moment. We'll try to restore it, and please bear with us until this is sorted. Thank you.
chemotherapy drug to be given
Bryony?
via the incorrect route. Hello?
Bryony, we
Have
have
you lost
lost
me
you
again?
for no more than 30 seconds. So if you just go back to your last sentence, that would be fine.
Okay. So do you have this slide?
We do have that slide. Yeah, we can see your slides perfectly. It's just the audio was gone.
Okay, all right. I don't know why that's happening. I've got good internet connection here, so I don't know what that's about. Okay, so I'll go back to the two extremes of this continuous line. So at one end of the continuum, we're imagining the most perfect prescription, perfectly dispensed drug, perfectly administered drug. It's clinically appropriate for the patient. It's clearly written and documented. It's signed, it's dated, it's legal. Even a really, really fussy researcher or a really pedantic pharmacist, dare I say it, will not be able to find any problem with this clinical situation. At the other end of the spectrum, we've got something that might be very clearly an error. So this might be something like prescribing a vinca-based chemotherapy drug to be prescribed to be administered via the incorrect route. It might be prescribing oral methotrexate to be administered every day instead of every week. So the kinds of things that nobody would be in any doubt that this was an error. Now obviously it's very easy to classify both of these scenarios. The one on the left is not an error and the one on the right is. But of course clinical practice is not black and white, and what happens is we actually very rarely get the scenario on the left and we very rarely get the scenario on the right. What we have instead is all sorts of shades of grey in between the black and the white. So what happens is that different researchers will define an error perhaps here. Another research group might define an error if it falls to the right hand side of the line here. Another group might put the line here. Yet another group might put it here. So we end up with enormous variation in what is counted as an error and what isn't. And what's even more difficult around this is not just the variation in definitions used by different researchers or different quality improvement teams, but that often the definition of an error isn't clearly defined in the paper, in the report or whatever. So it's actually very difficult to work out exactly what has been counted as an error and what hasn't. So what's really important here is within a given group, within a given quality improvement initiative, within a given research project, is having a very, very clear definition of what's being counted. Certainly for research purposes, what we do in our group is we start off with a fairly clear definition, and there's various definitions in the literature, together with a whole list of examples of things that we will include as an error and things that we won't. We then often find we still have many, many situations that we're not sure how to classify them. We end up having a sort of brief group who discuss each of those and decide which side of the line they fall. We document them so that we've then got a growing document that we call a kind of case law document that allows us to be consistent during the course of a research project, for example, to make sure that all the researchers are being consistent with what we're counting, and also that we don't inadvertently slightly change the boundaries over time, because that can also happen if you forget what you've decided previously. Now, for less formal projects, such as perhaps local quality improvement projects, there's perhaps not quite the same need to be quite so rigorous as that, but I'd still definitely recommend having a clear sense of agreement about what is and is not being counted as an error or a patient safety incident within that given context. The next issue that's important to consider is the choice of data collection method, and I'm just going to present one example here where we were looking at different methods for detecting prescribing errors in the hospital setting. So we wanted to compare prospective reporting by pharmacists. So this was based on pharmacists identifying errors as part of their normal clinical practice. We also wanted to look at the use of retrospective case note review, looking at the medical records and the associated prescriptions. We also wanted to look at incident reports. And then we also wanted to look at using the adverse drug event trigger tool, which I realise is not designed specifically to look at errors, but instead to look at harm, which then might result from errors or might result from adverse drug reactions. But we were also interested in comparing that too on the basis that we were using these other methods, just to see what that told us as well. So what did we find out? Well, we took the same patient cohort and applied all 4 of these methods to the same patients for the same 1-month period, each done independently, so that we didn't know what the other methods had revealed. And this is what we found. So the big circle on the left relates to the errors identified using retrospective review of the case notes, and we found 93 prescribing errors. The black circle on the right relate to the data recorded by the ward pharmacist, being recorded as part of his and her normal clinical duties. We didn't identify any cases of harm using the trigger tool, and we had 1 incident report during the same period, which was for an error which then wasn't picked up by either of the other methods. This is an example based on reviewing paper-based prescribing. We also did a similar study using electronic prescribing, and it actually revealed a very, very similar picture. So what this tells us is that whichever of these methods we used is going to obviously have a huge impact on the error rate that we detect. And also what's also important to note is that there's actually very little overlap between the methods. So to get really consistent data, this would suggest that we have to use more than one method, or at least be very aware of what the limitations are of any one method. And what it also tells us is that if we compare studies that have used retrospective review, for example, with studies that have used clinical pharmacist reporting, with studies that have used incident reports, then obviously they're not going to be truly comparable, because they're picking up different subsets of the same sort of population of errors within the system. So the third thing I wanted to consider in terms of study design was something about how often we collect data. So I'm here going to present a hypothetical example. Let's say we introduced an intervention based on medication review to reduce inpatient falls. The intervention was put into place in July following 56 falls being logged during the month of June. The falls were measured again in October, and only 15 falls were documented. So does that mean that we've got a successful intervention? On the face of it, it would certainly look like that. But if we look at how the pattern of falls perhaps might have been varying over time, we can see here that the intervention was put in place at the end of June, beginning of July. This is our June data here, showing the high rate of falls. This is our data later in the year, showing a much lower rate. But actually, if we look at what the average monthly rate of falls was in the 6 months before the intervention, it was 35. The average fall rate in the 6 months following the intervention was also 35. So it looks from this graph as if we just happen to have picked a very high monthly rate for our baseline measurement and a relatively low monthly rate for our post-intervention measurement. So we're in danger of drawing big assumptions based on those 2 monthly measurements. And what will be much more important is to look at the whole pattern over time, which then gets us into the realms of time series analysis, statistical process control charts, and other tools which I don't have time to go into in this particular presentation, but I know others have done so in previous webinars. But just to present an example of where we've used such a time series approach within medication safety, this was an interrupted time series study based on the introduction of a ward round based checklist for prescribing, which clearly shows both the pre-intervention and the post-intervention data, which was then published as this paper here. So I think it's important to think about how often we collect data, and that usually a time series type approach is much more powerful than a simple before and after study. I'm not going to spend time going through qualitative methods because in some ways this is a whole separate area which requires probably its own webinar or its own even series of webinars. What I'm going to do instead is just consider briefly using mixed methods for evaluating interventions. So mixed methods refers to the integration of qualitative and quantitative methods within the same study to answer a given research question, or might be a quality improvement question, which gives us then a much greater increase in breadth and depth. Now, it's quite easy to think about, well, anything that uses qualitative and quantitative is a mixed method study, but actually there's a whole range of different ways in which the two approaches can be integrated. I've added a reference to this slide, which I think is a very useful paper which describes the different ways in which the two can be integrated. So, for example, are they conducted independently, or is there some kind of interaction between the qualitative and the quantitative methods? Are the two given equal priority, or is one weighted much more than the other? And either of those is fine, but it's important to be clear about, be explicit about what the weighting that's being given is. Are they being conducted concurrently, or are they sequential? So, for example, does the qualitative follow the quantitative, or vice versa? Or is it something even more complex with some kind of multi-phase study where you've got a bit of qualitative, a bit of quantitative, a bit more qualitative, a bit more quantitative? And also, if there is an interaction between them, then where does that interaction or interface take place? Is it at the data collection stage? Is it at the analysis stage? Or is it later on at the interpretation phase? And all of these approaches can be useful within a given setting. It really depends what's appropriate to answer the question. So I'm going to finish off by illustrating a couple of examples of interventions that we've been involved with developing, evaluating and implementing in practice in the medication safety area. First of all, this was a study funded by the Health Foundation's SHINE programme. The Health Foundation is a charity within the UK that funds work around improving healthcare. This we called the Prescribing Improvement Model Study, and it was based around improving feedback to junior doctors about their prescribing errors. So going back to the stages I talked about earlier, we started off by identifying some of the root causes of prescribing errors. Our research group has been doing work in this area for a while, and based on various papers that we've done, the first one here was published in the Lancet in 2002, this second one here was published in the Postgraduate Medical Journal in 2011, and there's also been many other papers looking at the causes of prescribing errors within the UK. And all of these have identified a whole range of causes. But a common cause that's come up in many of them has been lack of feedback on errors to those that actually made the error in the first place. So to illustrate some of this with some quotes, this is a pharmacist talking about, for a relatively straightforward drug such as aspirin, most pharmacists would just add it onto the drug chart. They wouldn't contact the prescriber because it's so small. You wouldn't contact the doctor just to say, oh, it should be enteric coated or it should be dispersible. A lot of the time we'll just change it, we'll add modified release and without probably telling the doctor. So the pharmacists are talking about where they pick up a relatively minor error. The quickest and easiest thing to do is to just change it on the prescription, but actually the original doctor never gets to find out about it. Another quote here, a key issue is as well if you're in an area where there's a lot of doctors rotating, sometimes that phenytoin prescription is written by Dr. X. Dr. X has gone home, so I have to go to Dr. Y and get them to change it, and that's fine, they learn something new, but Dr. X, who wrote the prescription, doesn't know anything about it. And what we have is this idea of we're kind of scraping burnt toast. So for those of you in countries where having a slice of toast for breakfast is slightly less common than here, you might not quite get the relevance of this, but most of us often get our toaster settings wrong. You end up spending several days scraping the burnt bits off your toast, which, as the picture on the right shows, is actually much easier with a cheese grater than with a knife. But actually what we should be doing is getting to the root of the problem and altering the setting on the toaster in the first place. So in the same way, what we wanted to do was, rather than correcting errors after they've occurred, we want to try and make sure doctors know more about their errors so as to prevent them from happening again. So what we then did was we started doing some work around developing what the interventions might be. We did a pilot study of providing feedback to teams of hospital doctors about their prescribing errors. We then did some exploring the views of the stakeholders, both junior doctors and pharmacists, to look at what they felt the barriers, the challenges, the issues would be around providing individual feedback to individual doctors when we identified prescribing errors. So that then led to this piece of work which the Health Foundation funded around developing and evaluating an intervention to provide better feedback to our junior doctors about their prescribing errors and therefore increase patient safety. Because we use paper-based prescribing in our hospital, and in line with, I think it's about 87% of English hospitals at the moment, we have a real problem that often we can't identify the original prescriber because they've got a signature on the drug chart, which doesn't necessarily mean you can find out who they actually were. So we first of all had to do some work around encouraging prescribers to better identify themselves when prescribing. We then wanted to increase the quality and the quantity of feedback given by pharmacists to individual prescribers on their errors. We wanted to also introduce a group method of feedback to junior doctors based around an email of the fortnight highlighting a common or serious error. So this is just a few highlights of what we did. Again, we did some more work with our junior doctors to identify what some of the issues around getting better feedback would be. An important one I'd like to highlight is the one in the bottom right-hand corner, a junior doctor saying, "I'm often asked to amend my prescriptions, but I didn't realise that I've made an error unless I'm actually told that I've made an error." So we had this idea about doctors were being asked to amend drug charts, but our pharmacists are probably being terribly British about it all, and they're not actually saying, "Oh, there's an error here." They're saying, "Oh, please could you possibly change this prescription on the drug chart for me, thank you very much," but not being explicit about actually this is a prescribing error and highlighting where the doctor might be able to find the information or the resources to prevent that happening again. We also, as part of our stakeholder investigation, talked to some patients about what they thought, and I thought this was quite a helpful quote, really summed up the patients' views. Well, it's okay to screw up once, but there ought to be a process that says you've screwed up once and we're going to correct it so it doesn't happen again. What's unforgivable is if you've got the ability to go on screwing up time and time again. So to increase prescriber identification, we used PDSA cycles to do some work around introducing name stamps, which some of our doctors wanted to use, particularly if they had quite long surnames, so they didn't have to write that on every single bit of the drug chart. We also had to redesign our drug chart to make more space for them to print both their name and their signature. This shows an example of an inpatient drug chart where one of our doctors has used a name stamp which clearly indicates her name. So rather than just having her signature, KB, which all we'd have had before, now we have clearly stated her name and her bleep number. So if there's a problem, it's easy to identify the doctor concerned. We used PDSA cycles, as I said, to identify the issues around using the name stamps. And there was a whole number of things that we had to change. First of all, we had to add doctor as a prefix onto the stamps. We also realised that we'd ordered the name stamps based on the human resources list of junior doctors, which often didn't relate at all to the preferred names that they were using. So some doctors went by their middle name rather than their first name, or a shortened version of their first name. We identified, we had to change our message from not just use the name stamp, but to identify yourself when prescribing, because actually we didn't mind if they used the name stamp or not, as long as they had a clearly printed name, and so on and so forth. And I saw this paper the other day. This is published in the most recent BMJ Quality and Safety, which suggests that we all think of PDSA cycles as looking something like this, but the reality is probably something much more like this, and I would certainly support that as we experienced in this project. I've included some slides here that illustrate how we increase, sorry, I'll just go back to that one, the inpatient medication orders for which the prescriber was identifiable. We know that our baseline rate was around 8% before we introduced the name stamps. We then introduced the name stamps and we had a gradual improvement from about 45% up to about 60% in this particular hospital. Similar data from one of the other hospitals that we rolled this out to. This is just summarising some of the work we did with pharmacists about how best to give feedback to our doctors, specifying that they need to be more explicit that an error has been made. And we also suggested that they have a sort of pre-feedback agreement with the doctors in their clinical areas about how they would like to be contacted, how they would like to be told if they've made an error. So it's kind of almost like developing a contract between the two of them for how that will take place before it's happened, which then makes it much, much easier to have that conversation later down the line. We also developed fortnightly what we called prescribing tips, prescribing tip of the fortnight, which was based around a kind of spot the error case based on a real life error that had been identified, together with some tips and links to resources on the Trust intranet and to where they could find further information about it. Again, we used a PDSA type approach to develop these. A big issue was making sure that they were compatible with smartphones and could be read on iPhones, Android phones, as well as on a computer screen, and we were able to do that. We also learnt some things along the way, that although we anonymised the errors used in the spot the error cases, we found that the junior doctors were playing spot the handwriting. So we then started rewriting the examples so that nobody was worried that they'd spot their own handwriting and feel absolutely mortified, even though we were blanking out signatures and obviously patient names. So some of the key things that we found during this study, we estimate that we increased the percentage of that's Foundation Year 1 junior doctors orders for which they were identifiable from about 6% to around 50% across all the participating hospitals. Focus groups suggested real benefits of the intervention and no evidence of negative unintended consequences. We found some positive unintended consequences in that the name stamps were also being used in the medical notes as well as on the drug charts, and the doctors talked a lot about having an increased sense of accountability around their prescribing and documentation. We didn't find an overall reduction in prescribing error rates, which we did also measure using pharmacists collecting data, although we did have a small and statistically significant difference in the rate of reduction of error rate on the intervention site, but we suspect that producing a measurable reduction in prescribing errors is going to need a multifaceted approach, of which feedback would just form part. And hopefully what we've done is be able to start having some impact into having better information to doctors, junior doctors, about their prescribing, so that we're not forever scraping burnt toast. I'm just going to highlight very quickly one other intervention as we're just drawing to an end. As part of all the discussions that we had with junior doctors around prescribing, we found that a common issue was doctors had pieces of paper that looked something like this in their pockets, with lists of commonly used drugs and doses as their little local crib sheet. Now, these often were not necessarily up to date, not in line with local clinical practice, but were so loved and used by our junior doctors that they were well crumpled, well loved, and always in the pocket. So we decided to create something that hopefully served the same purpose, but was much more aligned with local practice. And we developed what we called the doctor card, which is the dose reference card, based on some commonly used drugs and doses. This is the one from a year or so ago. We're just in the process of updating it for this year, so we'll be changing things like the domperidone and metoclopramide dosing in line with changes to recommendations in those areas. This is the other side of the card, which includes some common protocols that the junior doctors were always looking up. We did an evaluation around this that highlighted that a few months after we'd given it out, the majority were still using the card, so the blue lines here are the yeses. We looked to see which parts of the card they were using most. Mainly it was the dosing guidelines for the individual drugs, although they were also using the warfarin and insulin bits. and they all recommended, or nearly all recommended, that it should be produced for subsequent cohorts of junior doctors. So I'm just going to say one or two things about publishing work in this area. I guess as partly with my academic hat on as well as my healthcare professional hat and as a journal editor, I would say definitely publish to allow others to share from your work. And as well as the normal things around publication about using the checklists and an appropriate choice of guidelines, as I said at the beginning, I'd really want to emphasize the importance of defining the context and the setting in which any study was carried out and clearly defining the definitions so that others can interpret your work. So just to sum up, I think what I hope I've been able to cover in a relatively short period of time, I think a lot of it comes down to selecting the right tool for the job. Now, whether this be the right data collection method, the right definition, the right way of publishing something, the right way of introducing something. Unfortunately, there are no magic answers, and it is about understanding what might be the right approach for your clinical setting. I will, of course, be very happy to take questions and discussions, and would just like to end there by saying thank you very much. And I'm sorry for any technical glitches that we had along the way. Julia, back over to you.
Perfect. Thanks very much for this fantastic presentation. We do have already a couple of questions, and as we have only 10 minutes left, I think we're just going to start with the questions straight away. The first one is from Rola Hamoud. She's asking, do you have any experience with trigger tools to audit medication errors?
I do, actually. Thank you for the question. As I mentioned in one of the slides, we used the adverse drug event trigger tool in one of our studies. We had to localize it for the UK setting because certainly the usually published adverse drug event trigger tool is based on American usage. So, for example, some of the drugs that are listed on the trigger tool were not drugs that were used within the UK, and it's obviously important to localize, I think, trigger tools again for a local setting. We did use it. I guess my main comments about it would be is that its use is so dependent on the standard of documentation. So a lot of the triggers relate to things like you know, an unexpected change in medication and what the reasons might be, or it depends on picking up things like lab results. And what we found was that it really varied as to how useful they were depending on how good the documentation was. So I felt as if we were more measuring how good documentation was, in which case you were more likely to get positive triggers, than we were perhaps looking for evidence of adverse drug events. I also know there's quite a lot of growing literature about it not having great test, retest or inter-rater reliability. I think where trigger tools may well be very useful is when they can be automated as part of a electronic health record and perhaps used in real time to highlight patients for whom they might need clinical pharmacy or other input to identify a possible adverse drug event so that it can be rectified sooner rather than later. I would see that as being a really sort of positive direction for that kind of work. So I hope that answers your question at least somewhat.
That's perfect. Thanks very much for that. The next question is from Subhashni Devkaran, and he's saying, I am a great proponent of time series analysis, but one has to manage seasonality and autocorrelation. What is your perspective using interrupted time series analysis for quality improvement?
I would agree with both of those points, well, all of those points, that I think time series analysis has enormous potential. Yes, you do have to consider seasonality. Obviously, seasonality is going to be more of an issue depending on the clinical context. So, you know, if we're looking at something related to chest infections or influenza or something that you'd expect to have seasonality, it's absolutely critical to take that into account in the study design, either to be able to control for it in some way or to make sure you've got a sufficiently long data period that you've got the whole seasonal effect. For some things, so the study that we did, we were interested in quality of documentation of prescribing in the inpatient setting, which you wouldn't expect a seasonal trend in terms of what you normally think about something being worse in the winter or the summer. But what we did have to think about was the rotations of junior doctors, and that you would expect doctors to have increasing experience over time. So we did actually use a control measure during that time, which was the quality of documentation in the medical notes, which wouldn't have been affected by our intervention, which was about prescribing. So we did attempt to try and control for that. So sometimes you can use a controlled interrupted time series analysis to try and account for some of those issues. The issue of autocorrelation can be calculated statistically, and in order to find out if you have got autocorrelation within there and taken into account as part of the analysis. And again, it depends on the data that you're collecting and whether you've got kind of, I can't think of the right word, but hangovers of effect from one data collection period to another. So if you're collecting data every day and you've got the risk of the same patients or the same healthcare professionals being present from one day to the next, then that's going to be more of an issue than collecting data, for example, once a month, where you're not going to have any commonality between your data collection units. But yes, thank you for highlighting that, because they are relatively important, but they can all be taken into account.
That's perfect. Thank you so much for this. Our next question would be from Patricia McKernan. She's saying, given that you did not see a reduction in prescribing errors, what are your research questions in order to identify the root causes?
I'm guessing the question is referring to the example I referred to around the prescribing improvement model study, where we were trying to increase feedback to doctors. So I'll answer the question on that basis. I think the further research questions are around probably around designing multifaceted interventions that collectively could focus on many more of the reasons for prescribing errors, and that might be more likely to pick up a measurable reduction. Lack of feedback is going to only probably influence some elements of prescribing. We also need to think about systems and protocols. We need to think about training. We need to think about role modeling. There's a whole series of things around there. And the problem is most interventions published in the literature have been a relatively, one-dimensional intervention that are only going to tackle some of those issues. There's also all the questions around electronic prescribing and how that can be used to facilitate safer prescribing. Obviously, it raises a whole new set of problems in some ways, but might allow us more scope going forwards for doing multifaceted interventions that build on that. But yes, I think it'll keep me and all the other people with an interest in this area busy for the next few years, decades, in terms of answering that question.
The next question would be from Maria, and she's interested to know what are the most common prescription errors.
Oh, that's a hard question to answer, Maria, because it will depend so much on the context. Are we talking about hospital? Are we talking about primary care within a given specialty? I mean, if we look broadly across the literature, the most common, I think, tend to be dosing errors, but it really does vary on what we're talking about. I think, I guess the other really common group is medication reconciliation errors whenever patients cross care boundaries, either being admitted to hospital or being discharged from hospital. But I think that's a very good example of where you have to look to your own setting as to what the issues are.
Thank you. Next question from David. He is expressing huge thanks for this excellent talk. And with regards to your points on incident reporting, have you looked at intervention to increase reporting via this route?
I haven't personally, although I know there is some work in the literature around that. I mean, personally, I think a big challenge is that often when errors occur, healthcare professionals, they don't know they've made an error, because if they knew it was an error, they probably wouldn't have made it in the first place. If it's to do with lack of knowledge or a poorly designed system or not having access to the information, you don't know that you've made an error. And it's only when perhaps you do some sort of detailed, more research-based method that you can find out some of those errors. So if somebody doesn't know they've made an error, they can't possibly report it. And in some ways, however many interventions you do to increase reporting, to remove barriers, you're never going to tackle the kind of you can't report what you don't know about question. But yes, there is work around trying to facilitate reporting, certainly making the reporting system easier. There's also work around the benefits of again, better feedback to reporters, so that you don't just feel you're reporting into a black hole, but you feel that something might be changed as a result so that people can benefit. And there is certainly work around there. So yes, thank you for raising that point, David.
Perfect. And there is another question from Patricia McKernan. She's asking whether you would be able to suggest a compendium of definitions for medication errors.
There are a whole range of definitions, and it kind of depends what you're wanting to look at. I don't know if my email address is available on the system, but you'll certainly find it on Google, Patricia. So if you did want to email me, I can send you a reference or two. That would be absolutely fine.
We can facilitate kind of emailing to yourself, so I'll forward your email address to Patricia.
Perfect, thank you.
And another one is from Julia Gilmartin. We are running out of time, but we are going to do our best to answer all of the questions, so bear with us a few more minutes if you could. She's again thanking you for this brilliant presentation, and she wished to know, in your own experience, how well do pharmacists accept research findings concerning dispensing errors? That is this information readily accepted, and do pharmacists view it as constructing information to guide their quality improvement activities, or are responses perhaps more negative or non-accepting?
Thank you for that question, Julia. That's a very interesting one. In my experience, it's been very positive. I mean, a lot of the work that we've done has been around the causes of errors as well as the numbers, and pharmacists that have sort of been able to look at the results and the data on the causes of errors, often around how things are stored and labelled on the shelves, and so often things are not easily differentiated, or there might be knowledge gaps, and they've been seen as things, well, actually some of these are things we can do something about, so that's really helpful. I certainly wouldn't like to say that oh well, it's always going to be positive everywhere every time, but in my experience I've had only very positive feedback and reactions to that. I think, like everything, it depends how you deliver the message as well, doesn't it? And I'm sure we're all very aware of the importance of making it into something positive that we can build on, rather than bashing people over the heads with the results, sort of thing. So yes, that's a very good point. Thank you, Julia.
That's perfect. I think we will have to wrap up. It's just past 1 o'clock now. So just to remind you all that the recording of this webinar will be available on ISQua website within 24 hours. So please pass this information to anybody who might benefit from this webinar. Let me express huge thanks to Professor Bryony Dean Franklin for this brilliant presentation, and thank you all for attending this session. Thank you as well for bearing with us in the moments of technical difficulties. Have a good day and goodbye. I hope you've enjoyed this session.